Thank you everybody for coming. 7:30, we're going to begin our session. My name is Luis Gonçalves. I co-direct the fetal imaging program here at Phoenix Children's together with Dr. Patricia Cornejo. And we are really delighted here to have today a fetal therapy interventionalist from the Mayo Clinic, Dr. Rodrigo Ravana, who I happen to know for a long period of time. So Rodrigo has a very interesting career. He graduated from the University of São Paulo in 1995, and then he spent, he did his residency also in the University of São Paulo in Brazil. Then he spent 2 years in France at the University of Paris doing a clinical fellowship in maternal fetal medicine. And when he was in Paris, he worked with a doctor called Yves Ville. And for all of us who know Yves, I mean, Yves is one of the authors, actually, the main author of the randomized clinical trial of twin-to-twin transfusion that actually made twin-to-twin transfusion the main modality of treatment for these twins. So Rodrigo has a wide range of interests, as he's going to show in his presentation. After spending time in France, and he went back to São Paulo, got his Ph.D., and his thesis was on volumetry of the lung using three-dimensional ultrasound. And after that, he was recruited by Texas Children's Hospital. So he spent quite some time at Texas Children's, first working with Tony Johnson and Ken Moise for 2 years. And eventually, he became the co-director of the Fetal Therapy Center at Texas Children's, under the direction of Mike Belfort, where he stayed until 2016. At the end of 2016, the Mayo Clinic in Rochester recruited him, and he is now the chair of maternal fetal medicine in Rochester, and also the director of the Fetal Center. And we're going to know much more about that as he speaks to us. So a round of applause for Dr. Ruano, and thank you very much for accepting our invitation.
So, good morning. You can see that I have a long story. I'm sorry for that, and I don't know the future. But I would like to thank first the hostel, the Phoenix Children's Hostel, for the opportunity. It's a pleasure for me to be here. I had the opportunity to visit the hostel, and I was impressed about the quality of the hostel, about your group too. I'd like to thank also Kate Van Lowen, Chris Lindblade, and of course, Dr. and my friend Luis Gonçalves. So I had a pleasure to see him again. And I'm going to talk about fetal surgery, the program that we have nowadays, and then I hope I will not scare anybody here. So don't leave, please. And then, so we are going to talk about fetal surgery. So I don't have any conflict of interest. But those are the surgeries that we can offer nowadays. And I hope in the future we are going to offer even more. For example, there is one surgery here in the list, on this list that I didn't put in this list yet, that we are going to discuss, for example, cardiac intervention for fetuses now. I know that the hospital here is very strong in cardiology. I have some people strong in cardiology. So we are now doing some fetal surgeries, even open the chest of the baby and doing open cardiac surgeries. So I'm going to try to speak a little bit about that too. But the focus of this talk is going to be for twin-to-twin transfusion syndrome. As Luis mentioned, I had the opportunity to work with Yves Ville, and when I was his fellow, we were doing the randomized control trial that he published in the New England Journal. So I had the opportunity to see a little bit of the history of the treatment, and we improved a lot the treatment nowadays. So we were able to improve the survival of both twins a lot. But the treatment that we do nowadays is a fetoscopic laser ablation of the placenta anastomosis, and we are going to speak a little bit about that. The other treatment that I want to talk is fetal endoscopic trach occlusion for congenital diaphragmatic hernia, and this is the main reason that I'm in the United States, because I learned this with Jan de Prest in Europe, 2004. He even published a paper about his initial experience, and I was helping him putting those balloons in France because he was traveling out of Europe. And then I had the opportunity to learn a little bit about that. And then once I came back to Brazil, I developed my career on that. And then I moved to Houston to develop the program, and the program in Houston was, thank God, was successful. And that's something that I really am passionate, and I fight for those babies, is about bladder outlet obstruction or lower urinary tract obstruction. I fight for those babies because the majority of people, they don't believe in the treatment. I hope at the end of the day, at the end of this talk, not at the day, I promise I'm not going to take that long, but I would try to prove that there is a way to treat those babies. And there is some babies that we can't eat yet, but we will be able in a short time. And then about spina bifida, of course, we can offer open and fetoscopic repair. But we have other rare diseases like amniotic band syndrome, that once the band can wrap around these extremities or the cord, and then we can lose the baby, or we can have natural amputations. So we can, nowadays, we are able to stop the progression of the disease. So we can avoid fetal demise by releasing the bands around the cord, or we can also avoid or prevent amputations by releasing the amniotic band. And there are different steps and ways to do that, and I can try to, I'll be open for discussion. I'm not going to focus much on this. But tumors, fetal tumors are very important because the mortality, once we have hydrops or cardiac dysfunction, the mortality is very high. So we can open the chest, we can open the belly of the baby, we can remove those tumors, or we can do minimally invasive procedures. And a fetal anemia, which was the first treatment in utero described. Interesting, I don't know if you know about the history of fetal surgeries, but this procedure was initially described using scopes because the quality of ultrasound was so bad at that time. So that's the reason that fetoscopy was developed, to see if we could, not me, but my old professors like Yves Gimes, for example, in Paris, he used to use tiny scopes to find the cord, to puncture the cord. Nowadays we can use ultrasound. And then there's a period of the time the fetoscopes were put away because the ultrasound improved and the procedures were done by under ultrasound guidance. But we have also bilateral hydrothorax that we put shunts. Shunts may work, but there are specific indications for that. For example, unilateral hydrothorax, we don't need that. Bilateral, we may need if there is an indication of cardiac dysfunction. I don't treat for pulmonary hypoplasia because we published some studies that show that those babies, they usually don't have severe pulmonary hypoplasia. They have more, the mortality is related more to cardiac compression, cardiac dysfunction. So heart is very important. The evaluation of the heart, fetal heart, is very important during the entire process that we are going to discuss here. And then, of course, cardiac intervention. So we can open aortic stenosis and pulmonary stenosis. We are doing this. But and also, we are open the intact atrial septum in a hypoplastic left heart syndrome. And then we are going to publish our first case that we did an exit procedure, open the chest and the septectomy, and then the procedure went very well. So this, I think our group thinks that this will open for different avenue for us to explore in the future, cardiac intervention. There are some people even trying to develop some extracorporeal circulation to try to treat the heart. And then chaos, which is congenital high airway obstruction syndrome. And then there was little because the baby had a natural obstruction of the trachea or larynx. And then once we clamp the cord, babies would die. Nowadays we can do an exit procedure and we can deliver just the head and the arms. We can monitor the vitals of the baby and we can do tracheostomy. But we are even offering this before the babies are born. Sometimes the patients, they want to know, have more information to avoid doing this only perinatal treatment, so they want to do fetoscopically. We call fetal laryngoscopic procedure. And then we can try to open in utero the obstruction there. But chaos open also a very interesting opportunity for us, and then we are going to discuss, is the trach occlusion for CDH. Why? Because babies with fetuses with chaos, they have hyperplastic lungs. So the idea, why not to reverse hypoplastic lungs of CDH, babies with CDH, by occluding for a while the trachea. So we are going to explore those four, and I'm going to go quickly for the rest of the anomalies. So laser for TTTS, which I think is the main common disease that we treat. So TTS is a very interesting diagnosis. Why? Because it happens only in monochorionic diamniotic twin pregnancies. Why? Because it's based on the definition. The definition is based on polyhydramnios in one sac and anhydramnios in another sac, or oligohydramnios. Some people, they ask us if we can see a monoamniotic twins. I think we can. The problem is that we don't have poly and oligo, and usually that's balanced, and then they don't have a real problem of expanding the uterus. But I think if we do fetal echocardiogram, we can see that one baby is having more difficulty in pumping the blood. So this may be a TTS, but we don't need to do laser because they keep stable. And why? I ask myself why they do better for this situation. And there is a friend, a professor in England, his name was Charles Rodek, that he decided he had a hypothesis before that if you do a septostomy, you could balance the fluid. So for some years before laser, people were doing that. So maybe monoamniotic twins, we have that situation naturally. But so we don't do laser for monoamniotic twins. So this TTS is only for monochorionic diamniotic twins. And the physiopathology is very interesting. It's an hemodynamic problem. It's a placental problem. It's a cardiac problem. So one twin is receiving lots of blood, lots of volume. So of course the bladder will distend it, and then polyhydramnios, because this twin is going to try to help by eliminate or urinating the excess of volume. But if we don't stop the problem, then we can have a congestive heart failure, and then brain hemorrhage, hydrops, and then we can have death. On the other hand, the donor, which is interesting, this baby is not donating anything, it's the placenta that's causing the problem, but we call donor to simplify our knowledge. But this twin is receiving less blood, less volume. So the bladder is going to be empty because this twin is going to have the blood coming to the most important organs. Then the bladder is going to be collapsed, so we are not going to see the bladder at one point. And then we have vasoconstrictions, and it's well proven that these babies, they develop in utero hypertension, arterial hypertension, tissue ischemia, and then they die. So I tell my patients that we have very complex situations because we have two different patients inside the same place, same uterus, with one placenta. And the reason for that is because monochorionic twins, one placenta, we always have connections, anastomosis. But sometimes the anastomosis, they become not balanced anymore, and the blood comes from one side to the other side. And then we have TTS. So TTS is just a consequence of blood flow coming from one side to the other side. And then the natural history shows that the outcomes are bad. So the chance of losing the entire pregnancy is about 80%. And we have those babies that survive, they will probably have 30% risk of brain damage. So it's a very severe disease. Usually if we don't treat, they deliver around 23, 24 weeks because of the excess of volume, polyhydramnios. And then we discussed there were lots of therapies, amnio reduction, septostomy, but none of them improved the outcome. The only one that improved the outcome was fetoscopic laser ablation that was described by Yves Ville. And now this is the technique that we use. We put a tiny scope inside the recipient sac, as you can see there, and then we identify anastomosis, as you can see here. So this was one artery, this was one vein, probably the donor is here, so it's an AV. And then we stop those anastomosis. Nowadays we do this procedure in 20 minutes, local anesthesia. Which takes more time is to drain the fluid at the end of the day. But then once we stop all the anastomosis, we make a line from one side to the other side, from here to here. We call Solomon technique, and we try to separate the placenta. Why? Because we want to avoid recurrence of TTS and also TEPS, which is twin anemia polycythemia sequence, which is a very difficult disease to treat. And we believe that TEPS is a consequence of micro or very small anastomosis that we cannot see very well. That's what we believe. And then those anastomosis, they change the red cells but they don't change, they don't allow to change the excess of volume. So those babies with those pregnancies, we don't see TTTS, but we see just anemia and polycythemia. And the treatment is laser that we are doing now. So once we do the laser, afterwards, we need to get some time for the babies. Nowadays, I changed my protocol. Instead of following every week, those patients before 28 weeks, I recommend to follow every 2 weeks, because we need to give some time for the babies to improve. So the first 24 hours, 48 hours after the laser, we do an ultrasound just to check the heart rates. Then after 1 week, we check if the bladders are present and the volumes are present. And then up to 28 weeks, until 28 weeks, we just follow every 2 weeks, amniotic fluid, bladder, growth every 4 weeks, and then the MVPs, the amount of amniotic fluid. I leave the fetal echocardiogram at 30 to 32 weeks, because if there is any problem, then we can treat postnatally those babies. And the chance of recurrence after this technique is less than 2% on our hands. It happens sometimes, but less than 2%. TAPS, less than 1% if we do this technique. And then the chance of having 2 babies alive is about 80%. So we improved a lot. When I started in France, we used to do a non-selective occlusion from one side to the other. Then Dr. Yville tried to do selective, but from the recipient side. But sometimes we cut big vessels. So we used to lose 50% of our patients, our babies. Now we lose about only 20%. So we improved a lot. We really find anastomosis. We just burn the anastomosis, and we try to preserve as much vessels as we can, as many vessels as we can. So this is an example of 17 weeks that we did the laser, deliver 34 weeks. We always have prematurity if we have 2 babies. We even recommend to deliver between 34 and 36 weeks, and then the babies are doing fine. So we have done 11 since 1 year that I was there, including 1 triplet. Sometimes triplets can be problematic because we can have monochorionic triamniotic. Triplets can be very difficult because we can have donor, donor, recipient, 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 donor. We can have one in the middle causing problems too. We saw some of those babies even at Texas Children's too. Spina Bifida. Spina Bifida is very interesting disease because it was the first one, and was the first one that we offered fetal intervention, but there was no life-threatening situation. So that means that we offered to try to improve the quality of life. It was the first fetal surgery with that objective. And the hypothesis behind that was very interesting too, because we believe that there are 2 hit processes. One is that when the anomaly happens, so some of the nerves are already damaged. But the second hit happens when the open spina bifida defect is in contact with the amniotic fluid, so we can have inflammatory toxic effects. Or the most important is that the CSF is leaking through the open defect, causing Chiari malformation. So our objective is to stop all those processes. And there is also a hypothesis that the fetus may move, and they may have trauma to the exposed nerves. So if we close that defect in utero, we may help stopping those processes. And that's what we do nowadays. So the standard of care is to open the maternal uterus. As you can see here, we use staplers. Then we can hold the membrane together, together the uterus. We use general anesthesia. So there are lots of discussion about the impact of gases to the baby's brain and heart. And then again, we discussed yesterday that we need to have a complex team, big team there, including cardiology to monitor the baby's heart. But we open the uterus with special staplers, and they work very well, I think. And we keep the membranes together. We remove the fluid. We monitor the baby nowadays. We use some electrodes to monitor the baby's heart too. And the neurosurgeon comes and the neurosurgeon does the surgery, close the defect. You can see here. So nowadays we even use microscope surgeries to close the defect. And then once we do that, we replace the fluid and we close the uterus and the membranes. Okay? Which is interesting is that we improved a lot the technique, and nowadays those patients, they deliver 37 weeks. I'm trying even to push to 38 weeks, but then I'm going against the guidelines because ACOG recommends us to deliver at 37 weeks if we have a classical incision. So here is worse, so I need to go to 37 weeks. But the patients, they're doing fine. So, and that, why we consider this a standard of care? Because there's a randomized control trial called MOMS trial that published, compared, during 7 years, compare prenatal surgery with postnatal surgery, 8 patients in each arm, and then they proved clearly that there is a benefit from fetal surgery. Why? Because we can reverse the chiari malformation, and according to this study was almost 100% in patients without fetal intervention to 64%. And if we see our data nowadays, we have reversal of chiari malformation in about 60% of them. So it's even better than this number. So only 40% of the patients, they still have chiari malformation. We do a second MRI, Luis, we do the second MRI 6 weeks after the fetal surgery in utero, and we can already see that there is a reversal of chiari malformation. I think this is the main benefit of this surgery. So you improve the chiari malformation, we reduce the risk of hydrocephalus from 80% to 40%, and that's the same. And then we reduce the chance of shunting. Of course, we have indirect improvements by cognitive aspects and all other aspects. But of course, we have some problems with the mother. Why? Because we open the uterus. We need to give lots of medications to avoid contractions. And then one of the main problems that we have is that those patients, they may develop pulmonary edema. And then we need to treat that. But we can have also PPROM, spontaneous preterm delivery. And the mean gestation age of delivery is 34 weeks, according to this study. For us, it's about 35 weeks now. But some of the patients, they get 37 weeks. But since we have some morbidity, and especially the main risk of this type of surgery is that we do the surgery, then we send these patients back to the MFMs, and the main risk that we have is not only prematurity and PPROM, the main risk that we have is rupture of the uterus. So we need to see those patients weekly. I keep medication, I keep nifedipine to stop contractions and or prevent contractions. And if they have contractions, we need to be very aggressive with magnesium sulfate because they can rupture the uterus. And then we recommend after deliver 37 weeks by C-section and wait 2 years for the next pregnancy. And the next pregnancy, we need to do a C-section again. So, and there's a new publication, I think, for SHOP that they found that some of those patients, they rupture in the subsequent pregnancies. So we need to pay attention to that. Because of that, we are trying to explore different opportunities or different options, and one of that is fetoscopic repair. And we went to Barcelona, and this doctor now is in Cincinnati, José Luis Perón, and he developed an interesting technique, which was very interesting. We went there to do to practice or to learn how to do that, and the first sheep died, the fetus died. So we created the Spina Bifida and died, and we decided, well, we need to plan the surgery first. So we got this fetus, and we put in a sheep fetus, and then we put in a black box, and we developed a new technique, which was very interesting, a single port technique, that we could put a patch over the defect. So you can see that's a sheep model because the type of placenta, and we put a patch, and then we glue it. And then we decide to do for the rest, and it worked. The problem is that in humans, it didn't work very well because the patch and the glue does not stay. Maybe because of the consistency of the amniotic fluid. Maybe there may be something different. But the technique that we developed was very interesting. We put some gases inside the uterus. So you can see the baby has half fluid and half gas. So the baby is floating, the fetus is floating on the fluid with the back part of the back of the fetus just exposed for us. Then we have opportunity to fix exactly the same way that we do with open or postnatally. So we can use fetoscopic instruments to try to dissect the placode and then to close the spina bifida. And then this was the first case, but we have published already a series of patients. And then those patients, they may have the the fetus may have the same outcomes, but the patients may have vaginal deliveries, and they do. 80% of patients had vaginal deliveries. We learn other things on this surgery, with this type of surgery. First is that we believe that the amnion could not be fixed, could not be healed, because there is no vascularity, but which is not true. So we can do sutures, and then the chance of PPROM is even lower than if I puncture and don't suture that. So we are exploring, we are investigating this type of healing process in the amniotic membrane. So what I'm trying to say is that the gestation age at delivery was even higher than if I put only one scope, for example, for tracheal occlusion. Why? Because we suture the membranes, and we treat the membranes in a different way too. But this is an example of open surgery at 25 weeks, deliver 37, and the baby is doing fine. So we have done 9 procedures there in 1 year. Trach occlusion. I think I'm going to spend the entire day here, huh? I'm enjoying that. So trach occlusion for CDH. Congenital diaphragmatic hernia is very interesting for me. And since I was a medical student, I wanted to fight for those babies. Why? Because when I was a medical student in São Paulo, I followed a physician who said, well, all those babies, they die. For us, it's a little disease. And then I had this in my mind. I said, well, we need to do something for that. And then when I read some papers from United States, the survival rate was about 40%. So for us, 0 to 40% was a big jump. And I'm going to speak a little bit about the history of that. But the CDH is a defect that the diaphragm does not close, usually on the left side. And we believe for a while that the problem was the defect, but in reality the problem is the lungs. The lungs, they don't develop well, and we have severe pulmonary hypoplasia, which is different than other diseases like oligohydramnios, for example. And we have also a malfunctioning lung, pulmonary hypertension. And that's where our focus is. And some people, they even believe that CDH is a cardiac disease. They treat very well the heart to improve the lungs. For example, the people from Boston, they believe in that. And then the other thing that is important for me is that during the fetal life, the lungs, they can be quiet because the placenta can exchange the gases. So we have an opportunity in reality to try to help those lungs grow while the baby may have good oxygenation. And I like to think as a MFM that the best NICU is the uterus. So if I can keep the baby inside the uterus while I'm doing some surgeries, will be amazing. I don't want to offend any neonatologists here, please. I'm just trying to help them to have less work. But which was very nice is that Dr. Harrison, who's an amazing physician, considered the father of fetal surgery, he tried to open the uterus and close the diaphragm in 1980s. I don't know if you can realize that. And then he had a very, for me, it's nice, those results, because he saw that the survival only with postnatal treatment, 40%. And then with his fetal intervention, only 15%. So he stopped it. He stopped the treatment. And why those babies died? Because when he brought back the liver, kinked the ductus venosus, and then of course obstructed the blood flow. So I think it was too advanced for that time. I think it's something that I would love to explore because we have better techniques to avoid that problem. But which impressed me is that then he decided to do the trach occlusion based on the chaos that I spoke before. And then 1993, he published a paper in the New England Journal comparing the trach occlusion with postnatal therapy. And then many people conclude, oh, trach occlusion should not be offered anymore. Why? Because they show that postnatal treatment was still better. But we need to read the paper very carefully, and even him tried to keep pursuing for better outcomes. The first outcome that he showed in this discussion is that the survival rate of postnatal treated patients improved in 10 years, especially during the trial. So there was a secondary indirect outcome of this trial. So the trial helped him to improve, to standardize the protocols in San Francisco and improve the survival rate. From 38% went to 75%. So it was a big jump. And then that's the reason that the trach occlusion didn't improve, because it was about 70% either at that time there. But the problem is that the trach occlusion that he was doing was completely was very aggressive. So he needed to open the uterus, monitor the baby, monitor the cord, so puncture the cord, and he used to open the neck of the baby and clip the trachea. So reversing the trach occlusion there was a big problem. And then of course those babies, they had difficulties and they died because of prematurity and difficulty of reversing. But then when I was in France, Ian Press developed this technique, which is very elegant, that we puncture the uterus with 2.7, 2.5 millimeter scope. We find the baby's mouth, we advance the scope through the trachea, and we put a detachable balloon that we were discussing yesterday. So this detachable balloon is useless for everything else, but is very useful for us. So the only indication to use this balloon is with us. And then this is an image that we have. So we put a scope nowadays. Also, we do in 10 minutes local anesthesia. We do local anesthesia to the baby too. And then we advance a tiny scope, as you can see. So we saw this is the trachea. We saw the vocal cords, the posterior wall of the trachea, and we will see the bifurcation here. And we place a detachable balloon there. And we can see that the baby is alive. The heart is pushing the trachea back and forward. So baby is fine. And we place the balloon just above the trachea, the bifurcation of the trachea, and we leave there. We place at 28 weeks and we move at 34 weeks. And then we prove in Brazil, without ECMO, that this improved the survival rate for very severe cases from 5 to 55%. And then we also demonstrated, following these babies every 2 weeks, that the fetal lung volumes increased after tracheal occlusion compared to those babies that did not receive the treatment. And the main importance is that the amount of blood flow in the lungs, in the fetuses after tracheal occlusion improved too, compared to those babies who did not undergo fetal intervention. Okay? And then I wanted more. So the question is that why some babies they survived and some babies did not. Remember, my survival rate was 55%, so I was losing 45%. And then we understand that those babies who responded better had a better survival chance of surviving. So then the third question was why those babies they don't respond well. And then the answer was that some babies they have a very, very tiny lung volumes. For example, 50%. 13%. Those babies are considered almost lethal. So then my question is that what should I do with those babies? Because I wanted more, and then I was presenting and I said, for this group of this population of patients, I will not offer fetal intervention anymore. Then somebody, again, my friend Jose Luis Pero said, why don't we put the balloon instead of 28 weeks, 24 weeks, to try to do the same as chaos babies have, you know? And then guess what? For this selected population, very selected population, we improved the survival rate for early tracheal occlusion to about 65%. And that's what I'm asking FDA if they allow me to do that. And it's very interesting. Once you have seen lots of those babies, it's always repeat the same way. So I have done 3 CDH, 3 fetos at Mayo Clinic. The third one I knew that was going to have this problem, the lungs didn't grow very well. So I'm requesting then if I can do it 24 weeks. And the mainly the other find that I observe is that the lungs keep growing. They grow better, but they keep growing for longer. So instead of only 4 weeks of growth, the lungs grew longer. And why? Very simple. If you go to embryology, of course, everybody remembers the phase of lung development. I don't need to discuss that. So that's the best phase of the lungs to be grown, you know. So that's the reason. So my main fight against the literature, against dogmas, is that I think the trach occlusion should be put at 24 weeks. And the prematurity rate was exactly the same, and the mean gestation age at delivery was only 1 week before, like 34 instead of 35 weeks. So we had similar results or even better for this population. But then we came to Texas, and we did the same, and the survival rate with ECMO was about 80%. So at TCH, they decide not to randomize the patients anymore. They think that's the treatment of choice for those babies. And then interesting, we reduced the chance of ECMO from 70% without fetal intervention to 30%. And I'm not going to discuss the risks related to with ECMO, such as bleeding in the brain. So it looks like there is a good impact of the lung growth. And that's what we are discussing in Mayo Clinic. We are considering, we have another philosophy of fetal surgery. The philosophy is that fetal surgery is a type of regenerative medicine. So we are regenerating lung tissue. We are regenerating neural tissues. And we try to regenerate also other tissues by doing the fetal surgery. Our experience, as I mentioned, 3 fetal procedures, 2 did very well, and with 1, the lungs didn't improve very much. The baby did better, went to ECMO, but the family decided not to proceed with, they changed for palliative care because ECMO was needed for a little bit longer. Now I'm going to talk about lower urinary tract obstruction. I have the entire day to discuss that. So this is a very rare disease. And why do I fight for those babies? Why? Because if you see the literature, the incidence, the frequency of these anomalies is about 1 in 10,000. I think it's more than that. Why? Because if you see the postnatal frequency or data is based on those babies who get to the NICU. And if you know very well the natural history of those babies, only 10% of the babies that I see, you see, the MFM see, will get to the NICU. At this Texas Children's Hospital, there was a very good neonatologist. He moved. He was the chief of the NICU. And then he wanted to try to do everything. So he was called for those babies. And I remember that he used to call me and said, "There's no way, Rodrigo. Those babies are not responding." So those babies, they die inside the labor and delivery room. So they die there. Why? Because they have severe pulmonary hypoplasia. Once we have a complete obstruction of the urethra, before 24 weeks, anhydramnios, those babies, they will die for pulmonary hypoplasia. And then 90% of them, they die. So the urologists, neonatologists, they are seeing only 10% of our babies. And then the rest of them, they have dialysis. I don't know if you have neonatologists here in the room, but you know that dialysis is a very difficult process, and the survival rate of dialysis is very low. Transplant too is a very challenging situation. So 90% of those babies who survive, or 70, 80, 9%, will need dialysis and transplant. So this is a very severe disease. But what I want to talk to you is that prenatally, we cannot confirm exactly what the cause of the disease is. Because we have posterior urethral valves in about 60% of the time, but we can have urethroatresia, we can have erythrostenosis, and we can have other disease. And we know nowadays that the prognosis of those the luto depends clearly on the type of the cause of the disease. Prenatal diagnosis, we can do the diagnosis first trimester. So we were discussing yesterday about the first trimester. And if we find that, we can do a 16 weeks, we can treat those babies, and we can change it completely natural history. But the majority of those babies, they are diagnosed in the second trimester. Maybe this is too late. And I'm proposing the fetal cystoscopy as a diagnostic tool too. Of course, if there is associated anomaly, the prognosis is very poor. But isolated luto, we can use ultrasound, and I use the same parameters that radiologists they use postnatally. Same parameters. So of course I see the oligohydramnios that we can see, but I see the cortex, if the cortex are hyperechogenic. I measure the hydronephrosis, although I know the hydronephrosis, the degree of hydronephrosis is not related to the prognosis. But the presence of renal cortical cysts and especially something that we call, many people, many of my families, they call, radiologists, they call multicystic dysplastic kidneys or multicystic kidneys. They are in reality renal dysplasia. Pathology, they call that renal dysplasia. Of course, and the correlation of the images are very similar. If you see macroscopic image and we see ultrasound, the images are quite the same. And I learn a lot with fetal pathology to do ultrasound. So we have the same. So I call ultrasound findings suggestive of renal dysplasia. Bladder volumes or bladder refeeding, very important to see if the kidneys are still working. Now, fetal urine biochemistry, I believe in that. We do serial biochemistry, and I can see the trend, the trend of the biochemistry. And then based on that, we try to develop a system that can help us to treat those babies. So we have stage 1, for example, that many people they treat in utero, we don't believe that we need to treat. It's a partial obstruction, and then we have normal amount of fluid. The kidneys are fine. If you do a puncture, if you do vesicocentesis, if you get biochemistry, normal biochemistry. You don't need to treat those babies. You just need to follow weekly. But if we have a severe form of luto with a complete obstruction, oligoanhydramnios, but the kidneys, we don't see any evidence of renal dysplasia or cysts, and the biochemistry is favorable, then that's the main opportunity for us to improve the outcome of those babies. But my problem is the stage 3, that I have already a severe form of luto, but the renal function is already abnormal. So what should I do with those cases? And then follow some of those patients, we identify even a worse group with a worse prognosis that we call intrauterine fetal renal failure or end-stage renal disease. This is the same that we see postnatally with end-stage renal disease, but we are seeing neutral. How? We have already signs of renal dysplasia, and interesting, some people they say, wow, these are dysplastic kidneys because the bladder is empty. It's wrong. If you see the bladder has a thick wall, and there is a keyhole sign, but the bladder sometimes is even smaller than the dilated posturethra. And then why? Because the bladder was dilated before, but now it's not dilated anymore. And then the amniotic fluid has if you get the history, the amniotic fluid progressively reduced. And then this situation is associated with death in 24 hours or end-stage renal disease. That means need for dialysis within 1 week. So we call it stage 4. And this is the image of renal dysplasia. And this is the image for the bladder that I showed you. You see, this is the dilated posturethra. And this is the bladder. See how the bladder is empty now? And then there's a thick wall. So what should we do for this with this case? They have mortality of 95%. The indication of fetal intervention here. So the main indication is for stage 2, when we have the opportunity to improve, to prevent severe pulmonary hypoplasia, because we can reverse the oligohydramnios, and we can prevent the end-stage renal disease. That's the main focus of our studies. So we want to preserve renal function. And we have 2 modalities. I'm going to speak very fast, but we have shunts that unfortunately can migrate very often, and we have an opportunity to do a cystoscopy with the same philosophy that my colleagues, urologists, they do after birth. So they try to identify the cause of the problem and try to treat the cause of the problem. So that's for our philosophy. There is a randomized control trial again that try to compare intervention, fetal intervention with postnatal intervention, but this trial was stopped before because of difficulties in recruitment. That trial was published in The Lancet for only one reason, to show how difficult it is to do a randomized control trial in a rare disease if you don't have a very established environment. So why, for example, the majority of patients that were selected, allocated for shunt, they moved to the other group and vice versa. So it was very difficult to understand the intention to treat, to do the intention to treat analysis, but the group did a treated analysis and showed clearly that there was improvement in survival rate. But they were not able to prove that the shunt could improve, could prevent end-stage renal disease. And why? There are two main problems of this study. They didn't select well the candidates for fetal intervention, as I mentioned before. And the second is that you can put a shunt, and if you don't follow that shunt, the shunt can move, migrate, can get obstructed, and we can lose the kidneys. It's true. So that's why we did a different treatment. But cystoscopy can help us to identify, so we put a scope inside the bladder from 16 weeks to 26 weeks, and we can identify the cause of the obstruction. If there is a membrane, we can try to open with a laser, posterior valves, or if there is an atresia, unfortunately, the prognosis is very bad. So those babies, you need vesicostomy postnatally, so the shunt is the best option. And then sometimes we have urethral stenosis that we just need to follow those patients. And the survival rate of shunt and luto, shunt and cystoscopy was better than no fetal intervention. We evaluated 100 patients, 111 patients in a multidisciplinary conference, multidisciplinary study, and we demonstrated the most important is that the cystoscopy was better to select patients, and then because of that we had better renal outcomes. And then the second result of the study is that the cause of the obstruction was important was an independent variable for prognosis too. So then many people will say, well, let's do cystoscopy for everybody. And that's the problem. Cystoscopy is a very challenging procedure. And then if you don't do well, we can cause some problems. And one of the problems is fistulas. And we can have severe fistulas, those here that were done in Europe, for example, and we can see that sometimes if people start lasering without knowing where they are lasering, they can open a big hole in the baby's back. So then there's a big pushback. So we need, and then we study why this was happening, and of course it was a technical problem. So we need to have good instruments and good technique to avoid that problem. So this procedure should be done very carefully. Okay? But if you see long-term outcome for those patients, the chance of being correct in the diagnosis, that means if I do the cystoscopy, am I correct to diagnose the real cause of the problem, we are good in 91%. If we treat, especially if we find posterior valves with laser, and then the recurrency is about 19%. And if we see that, maybe because the hole was not too big enough to keep that bladder empty, it's better to put a shunt to avoid to do another cystoscopy. And then the fistula is about 13% if you don't see very well. We are reducing those numbers now. But the survival rate after 2 years is about 55%, which is similar than the Pluto trial. But the chance of having normal renal function in 2 years is about 75%. Why? Because we select better those patients. Okay? And then, but the most important part of bladder obstruction is that in stage 1, we follow those patients every week. And if they keep in the stage 1, normal fluid, normal appearance of the kidneys, just the bladder is distended, then we have 100% survival. Why? Because if the fluid is normal, no risk of pulmonary hypoplasia. And if the patient, if the bladder is empty, the kidneys will work well. Okay? So no need for treatment. The problem is stage 2. In stage 2, if you do the fetal intervention, nowadays we have 75% survival with 70% chance of normal renal function in average. And stage 3 is our problem, stage 3 and 4, because the survival rate is less than 15%, and all of them need dialysis and transplant. And we are working on this group, so we are doing some research to see if we can improve the survival rate and get these babies to dialysis and transplant. So at the Mayo Clinic, we are trying to do transplant once the baby gets 10 months of age. So if we can accomplish that, then there is a solution for this disease. So it's very important to work in a multidisciplinary group to try to improve that. And there are different philosophies of fetal intervention for luto. One is to do primary vesicoamniotic shunt in utero and postnatal cystoscopy, or one is to do fetal cystoscopy and treat the babies or the problems by each cause, each problem. And then that's what we are investigating nowadays. Okay? I'm just going to finish with a very interesting case about luto. This is a patient that we saw at 16 weeks, and then the bladder was occupying the entire uterus. The heart was completely compressed. The baby was dying, and we put a scope inside. There was urethroatresia, the diagnosis. Then we put a shunt. Of course, the shunt migrated 3 times, so we need to put 4 shunts. We delivered 35 weeks, and the baby is doing very well. Lungs normal, kidneys normal, neurodevelopment is normal. The only problem is that this baby has confirmed urethroatresia. Nobody was able to reconstruct his urethra. The baby has vesicostomy, but is doing very well. And has, of course, pruning belly features too. So the baby is doing very well. Very fast, other indications of fetal surgeries, cardiac intervention. We do the balloon for aortic stenosis and pulmonary stenosis, and hypoplastic left heart syndrome with intact or restricted atrial septum. And we are also trying to explore exit to open septostomy or septectomy. We do amniotic bands. The amniotic bands, we have 2-step approach. So first we put a very tiny scope inside, and if we see that's feasible for us to do underwater, we use the laser to cut that. If not, we put gas. We increase the size of the scope, and we put scissors to try to cut that. And under gas, we can see better. But we can save, as you can see here, hands, and this is the mark of our laser. Tumors, we can open the uterus, remove those tumors, or we can do a simple gest of trying to coagulate the feeding vessels. Here the chest mass too, then we can open the chest or try to coagulate the feeding vessels, as you can see here. So if you coagulate the feeding vessels, the objective is to shrink the tumor in order to reverse the hydrops, improve the cardiac function, and we plan the delivery, and postnatally we treat those babies. So then we reduce a lot of the risk for the mother. So we are doing this too. And as I mentioned before, the last is a fetal laryngoscopic procedure that we can try to identify the cause of the obstruction or where the obstruction is in the tracheal larynx, and we try to open. We can use the laser to open, and if you open, we solve the problem. Then we don't even need to do an exit procedure for those babies. In conclusion, and I would like to open for discussion if I don't scare anybody here, but this is a multidisciplinary approach. It's not only me doing this, but it's OBs, MFMs, cardiologists, neonatologists, nurses, ENTs. I think the group is very big. And we do 1 or 2 days of comprehensive patient assessment. We have established multidisciplinary perinatal algorithms that I'm happy to share with your group. We have prenatal. Our goal is to do a specific good prenatal diagnosis, offer prenatal therapy for some babies, not very often, but the main importance of that is to plan and deliver the postnatal care. And then we have family care meetings to discuss step by step. We have simulations for fetal surgeries, fetal center meetings, and then it's based on many different societies. Our protocols are mainly based on the NAFNet, North America Fetal Therapy Network, consensus and then we try to do that. And then our hope is finally to fight for babies' lives. So, thank you very much.
Thanks so much for coming. The first time I saw you speak was last summer at an MFM meeting, and I couldn't figure out, are you an MFM? Are you a surgeon? Are you a urologist?
I'm nobody.
I think you're one of those guys that's all of those things, and so that's really comprehensive for your patients, and we really appreciate that. The question I have for you is about the indications for the balloon occlusion. Can you just tell the audience a little bit about how you select which babies with congenital diaphragmatic hernia are a candidate for that balloon occlusion?
Yeah, so that's a very good question. So we can offer to severe, moderate CDH. So severe CDH, we use ultrasound nowadays. Although we were discussing yesterday, we know here in the United States that MRI can provide the total lung volumes, and then we can have observed to expect total lung volumes, and sometimes the ipsilateral lung is more compressed or more hypoplastic, but we need to see the entire spectrum of the disease. So I prefer the MRI, And if the observed to expect total lung volume is less than 35%, it's completely known everywhere that this is severe form. And then we measure on MRI also the percentage of liver up, which is the volume of liver inside the chest with the entire liver. And if it's less than, higher than 21%, is considered severe. So these two factors are very good because they're independent factors. And if you combine there, I'm going to discuss this at 11, then that's the best way to predict that this is severe form. But the protocol is based on an European's guidelines, so they have more ultrasound available than us, than MRI, and then they use the lung to head ratio. So if the lung to head ratio is less than 1 or less than 25%, it's considered severe. So we measure the lung area, and the way that we measure the lung area nowadays is by tracing the area. So we did a very robust study, NEFNET, 40 centers, and we demonstrate that the agreement is better using the area. And I did a study with my fellow at Texas Children's. If we standardize the method, we improve the accuracy to predict outcome. So the lung to head ratio, less than 1 or less than 25%, is indication for trach occlusion before 28 weeks. If it's 25 to 30%, then it's moderate. I can do even up to 31 weeks. So that's the main indication now. I can share those protocols with you, but it's a very good question. Any other questions?
Fascinating talk. I was just curious, how do you actually do that? In the sense of how do you get these little microscopes 2 millimeters into the fetus's airway and then get down and take it?
That's a secret. That's a secret, man. No, but there is a technique, of course. I do different a little bit because I try to explore what neonatologists they do, and I try to bring it. So I do exactly the same as postnatal you do. For example, you try to extend the head. I can't. But I ask the baby, please extend the hand, turn it. So, but I try to change my probe. I put my probe down, like if you were holding the baby, and then I put a little bit higher, so then I go like almost straight. That's why it's faster. But then the main problem is that people get, so you have 2 points that you need to think. Who does ultrasound procedure knows that we need to have 2 points like straight, and then if the points change, it can be difficult. So the main objective is if you try to move the baby or if you try to press, then it's done because the baby is floating, So you need to try to avoid to go against the resistance. That's my recommendation, but it's training, I think. I have the entire day for you, don't worry. Yes. Good. What's your name again? Your name? Daniel. Daniel is asking a very good question. Is that when we do phase 1 trial, we need to move for the phase 2 trial, and then we need to move to phase 3 trial, and that's exactly what we are. So NEFNET is collecting that information for us, and then which is interesting is that, so his question is that after we do the trial, can we generalize the treatment for the population, So that's a very good question. So that's the reason that we follow the trial very well. For example, obese patient, I do, but I need to go out of my standard of care. So that's not standard of care anymore because the complications that I can have with morbidity, with increased BMI can change the outcomes, So we are in the phase of, in the United States, we're in the phase, exactly that phase that you mentioned. So we are post-randomized control trial, following the same trial criteria, and we are doing the same treatment to see how we are compared to the trial. And guess what? We are doing even a little bit better. Maybe because the trial took 7 years, 8 years to be concluded. So when we started, there was not that high experience. And nowadays we are following already with some experience, medications, toxicologies, all those things. So we are, I'm not, when I came to United States, for example, I was not very, how can I say, optimistic with that, because big incision in the uterus. But after seeing those patients, how they do, if they pass 1 week, if you follow very well, nowadays they can deliver 35, 36, 37 weeks. So we accomplished that. The main problem of this is that you can have uterine rupture, unfortunately. So that's why the fetoscopic repair may be a solution, But where we are at now, we are doing fine, but we are carefully evaluate each center to see if the centers are reproducing that. And there is a movement that if the centers are not reproducing or worse, then maybe the centers need to stop. They will have a stop for that. So it's a good question. It's a quality and safety issue. Yeah. Oh, please, go ahead. So then you are asking me, and again, a good question, because when I started this procedure, I tried to have some mentors. I was too young. So I tried to collect, okay, you saw that, my CV, I tried to evaluate the patients to learn as much as I could. And then I had the best population in mind, because all my experience was I put the balloon, 28 weeks. I established 28 weeks in order to avoid those, like, average, I tried only 28, 29 weeks. So I use simple measurements, 28 weeks, And then I decided not to remove the balloon, because at that time, first of all, it was not proved, and I'm not sure if it's proved, but it was not determined that you need to remove the balloon 34 weeks. So I was removing the balloon by exit. So that helped me to get more skills on exit, but I was worried about safety of the patients in Brazil, so I did exit for all of them. And then something that was very interesting is that those patients, they respond exactly the same way as chaos. So I just aspirate a lot, and then the babies did well after a while, once we stabilized the babies, before we clamped the cord. So I didn't have the same bad outcomes that the Europeans with exit. But what I'm trying to answer your question is that I had the perfect opportunity to do that test. I had, but I think I was too young, focused on something else, and I didn't have you asking me that question at that time, so I was not able to collect that information. And one day a friend of mine said exactly the same, why didn't you do that? You could have collected fluid, you could have did a biopsy. I said, because maybe I was not that smart at the time, So I needed to have some people ask me that time, but I want to do that. And nobody has done that. In France, they have terminated the pregnancy. Alexandra Benaki, I was there. She was collecting but it's only for termination of pregnancy. So probably those babies, they had more severe forms of lung disease. And she proved, according to that study, that there is no deficiency in surfactant level. But I'm not sure if that's the best evidence that we have yet. So, did I answer your question? So, thank you very much.